The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Welcome everybody to the Success in Practice podcast. Today I'm joined by Gary Fryer. Gary completed his osteopathic training in 1990 and practiced osteopathy in Melbourne, Brisbane and rural Victoria. Gary has been extensively involved in osteopathic education and research, teaching osteopathic principles, technique and research methods at Victoria University since 1997. He currently heads up the osteopathy program at that university. His research interests have been diverse and include the reliability of palpation, the use of osteopathic techniques by the international profession, the biomechanical effects of spinal manipulation, and the neurophysiological mechanisms of manipulative treatment. So I'm sure that'll give us plenty of content to talk about. Gary has advocated an evidence-informed approach to teaching and practicing osteopathy, and after completing his PhD in 2007, Gary moved to Kirksville, Missouri, for 2 years, where he conducted research with the A.T. Still Research Institute and taught osteopathic manipulative medicine at Kirksville College of Osteopathic Medicine. He has authored over 60 articles in peer-reviewed journals and many book chapters, and has been an invited speaker at osteopathic conferences in Australia, the US, the United Kingdom, Europe, Korea and Brazil. Gary, welcome to the Success in Practice podcast, mate. It's not a secret that I'm extremely interested in exploring osteopathic education in Australia, and I think you're the perfect guest to explore that with, and hopefully give our listeners some insight into that world and what you do there and how it's affecting osteopathy. So thank you for joining us.
Look, a pleasure. Thanks for inviting me.
Mate, what I like to do with everybody, and I'd love to do that with you as well, is to get a bit of background about you. So tell us about your story, Gary. How did you... tell us about you growing up, where you grew up, and what got you into osteopathy as a young lad.
Yeah, look, I born in Sydney, grew up in northern suburbs, or at least primary school days. Family moved to the Southern Highlands, and where I spent my my high school days. In fact, I'm going back there this weekend for a school reunion. And then, towards the end of school, I had no idea what I wanted to do. I was interested in film and done a little bit of dabbling in that in later years of school. Went to study at Mitchell College, at the time in Bathurst. Realised I was too shy and introverted to be a journalist, but I got interested in natural medicine and alternative medicine at the time. Initially through my brother, and decided I wanted to be a naturopath. So I moved back to Sydney and got into what was then the New South Wales College of Natural Therapies. Now this was early 80s, been 82 I think, and that was interesting. And at that time the college had an osteopathic department. Interesting time in Sydney, as far as osteopathy, because my first year we had an osteopathic department. The second year there was a big political fallout, and the whole osteopathic department left the college. Wow. And set up their own. I think it was Windsor College. Was it Windsor College? Pacific College. I think it was. I might be wrong. To graduate, their cohort as the fallout.
Was that I think it was George Stillian and a few of the others.
Look,
those names come to mind from talking to other people, but yeah, that's interesting.
Yeah, and I shared houses with some of the osteopaths, Max Belcher and others at the time in Sydney. So I continued and completed my naturopathic course, and over that time I got somewhat less and less disenchanted with aspects of naturopathy, which I thought were not well evidenced in science, and were a bit fringe, and I got more and more interested in this thing called osteopathy, which at the time seemed really rock solid in science and biomechanics, and at the end of that course I thought, well, can't see myself being a naturopath, but I want to be an osteopath. As it was, I heard at the time there was a new, the first government-funded osteopathic course starting up in Victoria. So I said, that's for me. I got on, packed my bags and got on my motorbike at the time and headed down to Melbourne. And went for an interview, and fortunately I think they saw my enthusiasm, and I got into the course. So that was in the first year of the new, it was then Phillip Institute of Technology course in osteopathy out at Bundoora, which later became, I think in '92, RMIT.
Yeah, right. Okay, and tell us about your experience there at RMIT. Like, what was that like? Who were some of your influences there, and what were some of the things you really enjoyed about it? And what do you think some of the things that at that time, let's not judge it as per today's today's standards, but at that time, what do you think could be done better?
Yeah, look, I really enjoyed my time. We had a small cohort. I think there were 15 of us. Going through the courses, the first cohort. It was a great time. Learnt lots of things, but in any new course, there are gaps and holes, and had changing staff, and major frustrations. Because of these gaps, had some great people teaching into it. Was able to learn lots, but then the downside was, particularly in the later part of the course, things weren't going very well, and I became somewhat frustrated. And I think in our yearbook I've got the they write of me, Gary Fryer, the only one to do it by correspondence. I just got so frustrated. I stopped attending classes, or I'd come to class and I'd open a book and read a book.
Can you explain some of those frustrations? I know, because I've talked to students, and current students are frustrated, and I ask them the same thing. So I'll ask you the same question. What were your frustrations specifically?
I think it were different circumstances than today. I think it was, to some extent, the personnel. At one point in time, there was somebody appointed that I think probably wasn't very suited to that position, and the classes weren't well structured, and many of us felt we weren't learning much, and so I'd sit in class and open Phil Greenman's book, Principles of Manual Medicine, just come out, and I thought, oh beauty, I'll make good use of this time. But that's a small grievance at a period of time. There were some great teachers there, and we overall it was a good experience. But I did come out thinking, oh wow, there were gaps in my knowledge. It made me. I had a burning desire to learn more when I came out. I was really aware of the deficiencies. I started doing various courses when I could over the next few years, seeking out people to learn from. I had to stay in Melbourne the next year, but then moved to Brisbane.
Let me ask you then about your early experience in tertiary education. What got you hooked? Like, when was that time for you where you said, this is for me, like I'm hooked, I'm all in on osteopathy? When did that happen for you? Were you a student then, or were you a young practitioner?
I think actually I was a student. I had the frustrations at the time of not feeling like we were receiving things in a way that was efficient and useful, and I could feel too much time wasted in some of the classes, and I don't want to mean everybody.
No, I understand.
But and at the time, and look, it suffered from a new course. There were big gaps that sort of recognised, and they recognised shortly after and tried to fill those gaps. So it was a student. I thought, oh boy, I think I could do some of this better myself, and it actually stimulated me to. I know you don't want to yet leave the tertiary setting, but as soon as I got to Brisbane, I started teaching a little bit in some natural therapies college there, in sort of a remedial therapy area, as a small supplement to the two practices that I was involved in.
And is that really when you became hooked as an osteopath?
Yeah.
Like you went all in on it?
Oh, look, I mean, I was hooked as an osteopath beforehand.
Right.
Even in the naturopathic course, there were a couple of osteopaths and some of the early influences that stimulated me to.
Yeah. Who were they? That's interesting. Who really influenced you early on?
Look, I mean, David Moore, David Legg, David Vivian Jones. Why all the Davids? I'm not sure, but Louise Adams. People were teaching in there and gave me a bit of a taste. I got hold of the. We did a little bit of muscle energy, and I got hold of the Mitchell Moran Pruso, 1979 muscle energy manual. And I thought, well, this is really interesting stuff. And some of those things, for instance, like the muscle energy, I expected to learn in at the Phillip Institute course, but we didn't. And
right.
There were various reasons for that, but
that's one of your frustrations, obviously.
That's one of the things I thought that I felt I didn't get, and I wanted to learn more. So some of it was technique based. I hadn't learnt much about muscle energy, different approaches to high velocity, other type of techniques. It was a reasonably narrow selection of techniques, and. Shortly after I, wanted to do, I did do, seminars with various people, Bill and the Couturers, Michael and William, came out and sort of, studied with them. Phil Greenman when he came out, Laurie Hartman, Vladimir Yanda, as an influence as well. So whenever some of these key people that I'd read about were available, I tried to enroll and do courses with them.
Moving on to early practice, I think it said that you practiced in Melbourne and then you went to Brisbane and then rural Victoria. Tell us about those years. What were they like for you? Were you somebody who kind of just accelerated into practice, or did you kind of just have to bide your time and find your way through?
I think, particularly getting to Brisbane, practice really went well. I was very lucky to go into two established clinics. One of them at that time was the West End Osteopathic Clinic with people like Thomas Whitten, who was a really great mentor in those days. There's also people like Mark Keyworth, who was coming down at that time and also sort of learning from. So it was a good environment, and practice was great. I was really busy, had another one with a more of a sports massage clinic, and sort of working between the two, and really liked it. They were busy, they were lucrative. Was
what was the landscape like up there in Queensland? I had a chat a few weeks back to Peter Lamb, and he was one of the first ones up there that helped really get recognition for osteopaths up there in Queensland. And so how did you find the landscape there? I think when you're describing your time, it was probably just happening. Was that like a bit of a, the wild, wild west up there in Queensland in terms of having lots of patients seek out osteopaths, having not many osteopaths there, and you having kind of a lot of patients there for you?
Look, I think it was, but we were also not well known, and it was just like after the Wild West had just beginning to be tamed, because the real pioneers like Tom Whitten were working there in the struggling for registration and
Yeah.
recognition. And so I got there in '92, pretty much just after that had happened, just after mutual recognition had occurred. I don't know if you know that, so mutual recognition meant that if you're registered in any state, you were
Yeah.
eligible, to be registered in any other. So suddenly, the New South Wales osteopaths that were locked into New South Wales and the Northern Territory were free to, practice in Victoria or wherever they wished, and so on. So it really changed the landscape, even before the national board. Yeah, it was interesting time because some of these guys they've done it really hard, lobbying and finally come good for them, even though we were registered under the same board at that time in Queensland as chiropractors. So I was registered there as a chiropractor and osteopath.
Yeah, right.
And should I have wished to, I could have gone back to Victoria and registered as a chiropractor because I was, registered as a chiropractor.
Yeah, the grandfather clause.
It was pretty crazy. So there's still a lot of things at that time that needed to be sorted out.
Okay.
But there weren't many osteopaths there, and
And so after Brisbane, you moved back to Melbourne, or you went to rural Victoria?
Look, back to Melbourne, back to Clifton Hill for about a year and a half, where again I sort of established a practice in Clifton Hill, only to leave it in a year and a half when myself and then my wife moved to Castlemaine. So I'd sort of, practice-wise, made a lot of decisions that weren't good for the practice, because who wants to leave a busy practice? And I left 2 really busy practices in Brisbane, to set up again in Melbourne, only then to do the same thing, moving to Castlemaine. But once back in Melbourne, initially I then reached out to Peter Gibbons and the group at Victoria University, and was able to start getting initially some casual teaching there, and at that time I was very fortunate because there were not many osteopaths who of any sort of experience that were interested in teaching.
Yeah, it's an odd our profession, not just our profession, but professions that really are service based. It's an odd thing because you could be a superstar up in Brisbane, earn a great reputation, and then, pick up your bags and go to Melbourne, and you've got to start from scratch again. It's not like it follows you around.
No, that's true.
But I guess once you figure out the formula, it's easier to rinse and repeat it. Just do good work, practice osteopathy, treat your patients well, and they'll invariably come back and rave and rant about you. And so at that time, you did some casual teaching at VU.
Yeah.
When was the period where you then travelled to the US, to Kirksville?
Well, that was not until 2006.
Right.
I moved to Castlemaine. I then got an ongoing part-time position teaching at the VU, so I would travel down from Castlemaine, where I had a practice.
This was your own practice, is that correct? Right.
My own practice, but in a multidisciplinary clinic. I was working with a physiotherapist, a psychiatrist, an acupuncturist, and a masseur. Yeah. So, travelled down, the hour and a half by V-line train, to VU to teach there. So, from that time on, I'd always had, some role in teaching.
Right, and then what made you go to Kirksville? Like, what was that? What kind of inspired you? I guess
it was. I had an invitation. So to go back a bit, it was the teaching at VU, and I was really fortunate to. Initially assisting with certain classes, to then I think it might have been in '98 or '99, be leading some of the then history and principle classes. And I started to research it. I started to get interested in what we were teaching, and it struck me that a lot of what was taught then, and certainly what was taught to me as a student, didn't have a really very broad evidence base, or at least I was saying, well, this is what they're saying. Do we really know this is what is real?
Can you give us a specific example, just so for the listeners, so they can kind of get it in their head what it was that
sure.
you were thinking in terms of having an evidence base?
Yeah, well, initially it was around the concept of somatic dysfunction. That we had. It was mostly justified as with the work of Core and Denslow, most of it being in the 1950s and 1960s. Due to my broader reading, I was aware at the time of concepts like central sensitization, that we now know as, or now call, nociplastic pain and so on. And I thought, well, how do these more modern concepts tie into these old concepts, which at that time really hadn't been revised or looked at? And so it really got me thinking and got me researching a bit and writing. And so my first article that I had published was published in 1999, and it was only published in the AJ, the Australian Journal of Osteopathy at the time, so not really anything other than a local journal, but it was somatic dysfunction, and I was updating the concept, and from that I started getting more interested in research. The VU had always emphasised integrating research and having students do minor projects, so I started supervising projects. I started some of those became publications. I got more and more interested in it. Thought, hey, I see this as something I'm really interested in, the teaching and the research, and I guess the sort of the commentary on it all. And I enrolled in a PhD, and that PhD was involved a series of studies, but was around the concept of palpation and palpation of paraspinal muscles. Initially looking at palpation for pain using a sort of specialised pressure sensor on the finger, and trying to essentially determining that when we palpate this paraspinal tissues that feel abnormal to us, and often the patient goes, oh yeah, you got the spot, and we've all had that, and because that struck me as something's going on here. What is it that we're feeling? Well, I could determine that these were actually more sensitive spots than tissues around them. So it's not palpatory illusion, or we're not unconsciously pushing harder. That we were identifying things that were tender based on the palpatory findings.
Yeah, right. And you found that I mean, the results of that study, was that something that reinforced what you were doing already in clinic, or did it challenge what you were thinking?
Oh, look, it validated that. Yes, we are palpating, something, real things. We can at least palpate sites that are tender, based on not just the report of tender, but on often the palpatory characteristics of the paraspinal tissues.
Yeah, some of the criticism around that is to do with more inter-rater reliability. Can you speak to that in terms of different practitioners trying to feel the same thing? Has that something that's still an issue?
Oh yeah, absolutely. And I've done a number of inter-rater reliabilities, and so have a lot of other people. And regretfully, most of them show poor inter-examiner reliability, and probably the best thing we're good at doing, or the most reliable thing, is palpation for pain or tenderness.
Right.
So we're not bad at doing that. We're not very good when it comes down to segmental motion characteristics. So you say, 5 osteopaths examine this person and tell me which is the most restricted segment. We don't tend to agree.
Right. And I guess that would make sense though, right, Gary? Like you being, you're an experienced practitioner as well as a researcher. Practitioners of varying experiences would have varying, palpatory sensations. So would that be something you'd expect in terms of having 5 different people come up with 5 different things?
Yeah, look at, there are a lot of reasons, and from idiosyncrasies of how people palpate, to the actual experience of what's important. And in a couple of studies we tried to work out why we were different, and even with tissue texture, some people were feeling what was light palpation, some were feeling the edge of it, some were feeling deeper, and so it's really very difficult to standardize these things, and it's really an experiential thing when you palpate. But the reality is, if you're saying we're palpating the same thing, we can't. It's difficult to objectively show that.
Fair enough. We'd all agree with that. I don't think that's that's definitely something that wouldn't be debated. And so you ended up in Kirksville by invitation, from what you're telling us.
Yeah.
And tell us about your experience there.
Look, it was brilliant. Yeah, loved it. So I was invited.
You're in a time capsule. You're really in a time capsule there.
Oh, well, in many ways, yeah. So I had a position as a research associate professor there to continue some of my PhD research, because it aligned with the research aims of people like Brian Degenhardt, who led and still leads the AT Still Research Institute. And I also, in addition to that, I was also part of the teaching faculty at Kirksville College of Osteopathic Medicine, within the AT Still University. So, look, amazing experiences. Firstly, just being there. You say it's like a time capsule. In many ways, you walk out and it feels like, boy, is this the 1950s in some ways, or it did then. Things are changing now, but
you weren't digging up cadavers, mate, and doing your research on those, were you?
Oh no, look, they had great, but just the look of the buildings, the look of everything. It's sort of think, wow, this, I'm not in Kansas anymore,
right.
But it was it's such a wonderful experience looking at the historic areas. The museum there is amazing. The monuments, the still. I got to play around. I got to see some of Denslow's original EMG equipment, and in the old ATSU annex. Actually, when I went back there last year and I stayed with friends of mine who'd bought a house there, they said, we looked at the deed of the house, and the previous owner is an Irvin Core. I was staying in the old Core house, the family home, and just really.
That's brilliant.
It's steeped in history, and I was just so fortunate and privileged to be there.
Yeah, that's amazing.
And it also allowed me to do research in various areas and have support, have modern EMG equipment and other things.
Well, tell us about some of that specific work that you did, the research that you did over there. Run us through that and what you were able to achieve over there.
Yeah, look, there are a number of different studies I was involved in, but my focus was furthering some of the EMG work that I'd done in my PhD, and basically it was trying to re-examine some of the original Denslow work. Now, going back in the some of the like the 1943 paper, reflex activity of the spinal extensors by Denslow. Basically, what he did is put in needle electrodes into the muscles, found a lesioned area that he palpated the tissues and a little bit of joint motion, felt abnormal, put a needle electrode. Now, electrodes are measuring the deep motor activity of the muscles at rest, and had control areas. And then in that seminal paper reported that there was spontaneous activity at the area designated a lesion, but not at adjacent control areas. And so it supported the neurological lens, later the facilitated segment concept, that these things were firing off spontaneously at rest when they shouldn't be, abnormal alpha motor activity in that area, and that might be related to also the palpatory findings if you've got a little bit like the muscle spasm concept. So I wanted to try to re-examine that. In one of the studies I did, I had to go to Melbourne Uni for my PhD, and we used their equipment, but it was actually quite antiquated, the EMG stuff, and initially it seemed to support that hypothesis, but we later found, on re-examining it, that we had some contamination on some channels, and you really couldn't say anything very definitive about it.
Right.
So I did it again with where we had 2 osteopaths to look at consensus palpation to locate an area that appeared abnormal in the thoracic deep paraspinal gutter. What Greenland says is where you palpate for the 4th layer spasm, presumably rotatories, and we did a trial to make sure that when we put the needle in, we actually take it right down to the lamina, then withdraw it, and it leaves these fine wires embedded in the deep rotatories muscles.
Yeah, right.
So my hope was to then, look at how it is at rest, like Denslow did, apply pressure to various parts of the spine, like later studies did, then do some functional studies where they're moving around and seeing how they behave. But unfortunately, unfortunately, so many of my studies are plagued with problems. Indwelling fine wire EMG is a black art.
Yeah, right.
And we had all sorts of problems where, we're losing signals. As soon as they got up, we lost signals because the wires were migrating.
The technology issues.
Yeah, which it just part and parcel of the fact that there are really deep pressures generated by these deep muscle fascicles. We'd pull out the wires sometimes, and they would be kinked.
Yeah, right.
Representing the and so really, I hope to do a whole lot of things, but we were contained to just doing the resting study, because as soon as they weren't resting, we lost signals. And unfortunately, that didn't support the hypothesis. We didn't find any different activity at the so-called abnormal spots relative to the spots above and below and on the other side.
Well, it sounds like you weren't able to measure it properly anyway.
No, look.
At rest you could, but not functionally. Is that correct?
Correct. But the original study that Denslow did was at rest.
Right.
So we could compare to that, but we couldn't really take it further as I hoped we might. We did later a manipulative study looking to see, well, does manipulation change the at-rest activity? Which again, not meaningfully. It decreased a little bit for the counter-strain technique, not for the high velocity, and not for the sham control.
Yeah.
But it could just be the fact that the reduction, it's only like about 3% reduction, was not just at the target site, it was at all sites, and it could just be the general relaxation.
Given your experience in research and everything you've just mentioned to us now, are you of the opinion that it's the totality of the treatment rather than the actual technique? Like, how much does that play into it? Like, you have an osteopathic treatment, there's 3 or 4 things you might do as a practitioner. All those things come into play for the end result. Is that really what we're concerned about as practitioners, rather than the effectiveness of one particular technique?
Look, I think it's multifactorial, and all these things may play a part. I wrote a few years ago a 2-part series on the mechanisms of treatment in a biopsychosocial context, and basically the upshot of is, I think, depending on the patient, there are tissue factors which are quite likely to be affected by manual technique. There are neurological factors, certainly to do with pain, but also proprioception and motor integration, which may be influenced by various techniques. And then there's the psychological sphere, or psychosocial sphere, which clearly can influence things too, producing a sort of a top-down effect on the neurology, and then on the tissues, and the tissues can do a bottom-up,
Well, and clearly we don't have a lot of effect on that, right? Psychosocial. I mean, we don't, as practitioners, we don't have a lot of input into that.
No,
And
I disagree.
yeah,
I think we can have really big input into
right.
it by the way, by identifying things like yellow flags, people's
Mm.
beliefs about things, the way we frame their disease and their progress. Because and I'm sure you'd be aware of things like explain pain and
Mm.
pain science about that
Yeah,
highlights how things we say can make a big impact for better or for worse. Now,
right.
if we, for better in that, empowering patients, reassurance, getting them to be active, framing things or framing our treatment, being positive, but also if we reinforce poor beliefs. Say they've got a belief about their back that it's really fragile, and it's particularly people
Mm.
with chronic pain, where the psychological how their beliefs about pain can upregulate their pain mechanisms and so on. If we say to them, "Oh, you're lucky you came in here. Your hips are twisted. I'm gonna twist them back," and then I go away thinking, "Oh my God,
Lucky I saw Gary today.
exactly how fragile I'm at. I better be really, really careful, or they're going to twist out again."
Yeah.
And a couple of days later, they get a twinge, think, "Oh God, I've done it again. I've got to go back to him, and he's got to put them back in place."
Yeah, no,
Um,
I get
it,
that. I'm more talking about I guess, some of the things that might be a bit more out of control. Like, I saw a patient 4 or 5 days ago, I think, that was going through a divorce and,
sure.
having a lot of things happen and kids and so forth and pressures of life. And I guess you have to also understand your scope of practice and see what you can and can't help with. But you're right, framing things,
Absolutely.
and I guess framing what to expect, patient expectations. You could say, look,
Yeah.
you're having a tough time at the moment. Your body may not respond the way you would normally expect it to. So just be patient with the results, something like that. And that's more to what I was talking to. But I totally get what you're saying in terms of making sure that we explain pain in the right way and not let, I guess, some concepts that are obviously not correct creep into our speech with patients. Yeah, so that's important. I want to move on to, I guess, well, I want to go back a little bit, but I want to ask you about your current role with VU. But I mean, we discussed your particular education at RMIT, and you said that there were some things later on that you weren't quite happy with in terms of the delivery of the course content, and I guess that, I mean, it's not yours, but just everybody's experience through education would probably affect how they would view how education should be given at the moment. And I guess, given your current position as the head of the program at VU, how did your particular experience at RMIT, I guess, affect what you're doing now at Victoria University? Hello, everyone. I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow, and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you, and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode. And please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
I'm not sure, it had a direct input other than to originally make me interested in teaching and make me, want to present things better, present them. I think at the time I felt I wanted more. I actually did want more, scientific backing to some of the claims that were made. I also wanted a, broader range of techniques that at that time. And just remember, I was in the first year, and big gaps there, as in any first year of a new course. And things did change, I'm sure, at RMIT after I left. But look, it made me also seek out knowledge, not just osteopathic, but more broadly. And in a couple of years, I realised, well, this osteopathy knowledge that we've got, you can really dive deep and so on, but it sits in a larger body of evidence that many osteopaths don't get exposed to, because they're just, at least at that time, were just looking at osteopathic texts and not going more broadly. So I wanted to, I guess,
broaden the horizons.
I've always thought modernise the curriculum a bit, so that to bring in more broad information that was relevant to osteopathic practice. Right.
Okay. And so I guess moving on then to your current role at VU, tell us how that course has transformed over the years, especially in the last period where the block program has kind of moved in. Tell us about that. How has that course evolved? I think, how long have you been there for now, Gary?
Look, I've started
as head of the program.
Oh, as head of the program. I think it was probably about 2011 or something like that.
And you were there before then, teaching.
Yeah, I was.
Right.
Yeah, in a
and
teaching role.
So you've probably been there, I think, since 2007, from what you mentioned earlier.
Yeah. Well, I have been started teaching there, I think, in '97.
Wow. Okay. So there's a good almost 30 years there of teaching. How has that course evolved, especially given since 2011, since you took over? How do you think it's changed, or tell us about it?
Look, there've been lots of changes in lots of ways. Some, I think, and we've operated as a teaching team. It's certainly, I don't get to say what's happening and as a lone voice. But over that time, I think
what are some of the big milestones do you think that have changed?
Well, certainly the block mode teaching has been a big one, so that's I don't know if you've heard the term.
I'm going to ask you some specifics around that in a minute, but I just want to understand the evolution of that course, and I guess how it came to be and how it's evolved in the last probably 10 years.
I'm not sure I've got an easy answer for you, because any course, the evolution is incremental, and things change every year. Everything's sort of reviewed by the people that teach in it.
Yep.
We've had a series of course restructures that, in one sense, the volume of teaching has decreased, and this is not just our course, but I think most courses. Simply that, when I joined there, I think students were probably doing like 26 hours a week, face to face. That's reduced hugely, and that's been I think a trend in all these sort of allied health courses too. But
why do you think that is, Gary? I mean, it's been an issue that's been brought up to me by people that that want more face-to-face stuff, that want more, I guess, connection with, especially experienced practitioners to come out and teach them.
All our teaching's face to face. I mean, there are some very small online parts to some units, but every unit
is accreditation.
We don't have any.
Does accreditation play a role in that? Like, do you feel like when you go through an accreditation process, are there certain, I guess, forces or influences that kind of are pushing all the health science degrees into a certain direction?
Look, yes and no. On one hand, they're not very prescriptive to do with content or certain content or even sort of overall teaching hours. But on the other hand, particularly with the changing standards, there's a need to align with changing priorities and standards. And if you look at the most recent standards, you'll probably see, the domains relating to being an osteopath are only really the first one, and then there's the domains about being an educator, being culturally appropriate, being a leader. There is one of integrating evidence. So any course needs to demonstrate to the accreditor that everything we're doing is mapped to these standards, and when they change, and as they did a few years ago, that does mean there's often a change in priorities in a course, and rarely is it the priority, unfortunately or unfortunately, going to be more hours spent on osteopathic philosophy or more hours spent. It's going to be teaching, producing graduates with broader capabilities, and I'll talk about that maybe a bit later if you wish. About where we're heading, but
we'll touch on that later. I want to ask you though. I mean, look, you're an osteopath. There's no doubt about it. You're an osteopath with a capital O, right? You've been to Kirksville. You understand the history of osteopathy. You've practiced it. You've gotten great results with patients. You've put in the time in research, and now that what you're telling me is that that the courses are trying to give a broader expansion of, I guess, what practitioners can do. But in that process, are we losing the osteopathy in the osteopathy programs? Are we losing the essence of what makes us a little bit different than, say, a chiropractor, a physio, or an exercise physiologist?
I mean, if I can just come back to that a sec, because if we talk about how it's changing, we're seeing a big emphasis on things like exercise, rehabilitation, looking at psychosocial determinants of health, all these sort of you might say more generic health issues, but we would argue still really relevant. And it's what also got to be mapped to what the accreditor says we need as well. So are we losing osteopathy?
Before I let you answer that question,
sure.
I understand what you said then, and the point I want to make to that is that obviously you use the example of exercise and how we're utilising more exercise in treatment. There's nothing wrong with that, and exercise is just another tool in the toolbox. And I think what really separates us is how we think, rather than what we do. And that's, I guess, the question I'm asking you. Are we losing that? Are we losing that osteopathy in the program? Is that something that's, whether by design, I don't think it is, but whether it's by design or by just the forces of what's going on, is that what's happening? Are we seeing that? Are we seeing a little bit of a decline in the way that we think, and how we're teaching students to think about, I guess, the body and somatic, or not somatic, but disease?
I think it's changing, but I would argue that we're not losing osteopathy. But then that comes down to what your definition of osteopathy is. And, listening to yourself and with Anne Cooper, and having heard lots of other voices on the subject as well, I know, particularly if you're a practitioner who maybe trained some years ago, or you were a pioneer like so many of us have felt, and many of the New South Wales older graduates, they had to really fight for their degree. They feel a real passion, and they feel, this is osteopathy. But when you ask any of these people, okay, let's write down, or let's really clearly explain what is osteopathy and what is being lost, most of them really struggle to say anything other than a number of sort of common sayings and platitudes. And this goes back. I think it was about. Sorry, I should have the date, but it was about 2012 maybe, when we had the IJOM, International Journal of Osteopathic Medicine. I was a guest editor on a special issue for osteopathic principles, and I really wanted a broad range of views on, from the traditionalists who say traditional osteopathic principles are really important and this is why, to the like progressives who say no, we've got to move on, we're doing evidence-based medicine and there's no, it was really clear it was a major struggle to get anybody to put pen to paper to actually say what what were osteopathic principles and what weren't being taught and why they were important. And I think, beyond the four Kirksville principles and the connection, the concepts of holism and the interconnectedness of the body, it's difficult to. When you ask an older practitioner says, you don't do osteopathy like the real osteopathy, to actually get them to say what that is. And I think it ultimately it's a bit of an experiential thing, or a culture of practice, rather than something that can be detailed. So, do we teach osteopathic principles? Yes, we do. However, they're definitely not as up in front as they might have been 20 years ago.
Look, I guess the proof is in the pudding, and what some of the feedback has been is that recent graduates, not just Victoria University graduates, but recent graduates across all three universities, are struggling to know what to do in treatment, especially when there's no textbook or evidence base for that particular problem that they're seeing in front of them. And where a lot of guidance is coming in with a lot of more experienced practitioners is like, hey, have a look at this, have a look at that. And they're having to do a lot more of that with recent graduates than what they've ever done before, because they feel that, I guess, the principles aren't being, they're being taught, but they're not being taught in a way that they can be extrapolated into diagnosis and treatment. And so I guess that's just feedback. You probably don't even have to answer that. That's not a question. But I just hope that that's being considered at university level, and that at least in 10 years' time we can say that we're still a different profession in terms of what we do. Because I guess we have to have a point of difference, right? Like, there's got to be a point of difference to what we do versus, say, another profession. Otherwise, what's the point? We may as well just all do a health science degree. So, look, moving on to, I guess, another question that I have, and this is just my own bias with New South Wales, I guess. Mate, Gary, we're very desperate for a course here in Sydney. Why can't we take the course that you have at Victoria University and teach it down at the campus that you have here in Sydney? What's stopping us from doing that?
Look, I would say resources, maybe, the whole lot of resourcing issues. It's probably something
you'd have to be one of our champions.
Taken up, but look, it's probably something better taken up with the Osteopathy Australia, and then if they thought that was really required, and I don't know. I mean, universities are funny beasts, and being in a university doesn't necessarily mean I'm a master of my own area. In that there are layers of governance and bureaucracy. But look, if it's something that the the association, really wants to push, then I'd certainly be happy in whatever
Has the
role I can
association ever
to push.
approached you? Have they ever approached you and said, "Look, we need a course in Sydney. It's the biggest market in Australia, and not having osteopaths graduating out of Sydney is a real shame." Gary, you may not be able to just wave a magic wand and create a course for us, but you have a campus in Sydney, a VU campus. You have access, I guess, to the people that can make decisions at Victoria University. You've been you've been a great champion of osteopathy over the last 30 years of education. Can you help us? Can you do something with us as an association so we can get a course up there? Have you ever been approached and asked that?
I'm very aware that there is a strong desire to have a course in Sydney, and I know that a number of avenues in Sydney have been explored.
Okay. Right. Okay. And I guess if the association had approached you, there would be no issue in terms of you having a discussion with them and letting them know what.
Not at
There
all.
might be some barriers. There's probably some barriers to, as you said, resourcing barriers, and I guess the university itself wanting to expand, and whether it's able to or not able to. But at the very least, we can ask the question, right?
Oh, absolutely. And, in whatever role I can play, I'd be very supportive. And the Sydney campus of VU, I think, sort of operates somewhat, certainly independently from my college, and but
If the association could come up with a very viable business solution, I guess, for the university, it might be a good opportunity for, I guess, that both parties to sit down and have a chat.
Look, I'd be certainly happy to be involved in such
Great.
discussions.
Great.
But I can't attest to what logistical hurdles there might be. But
Yeah.
you don't know till you have a chat.
Look, you mentioned earlier you were listening to the podcast with Matt Cooper, and I had this discussion with Matt, and so that's why I'm asking the question, because I guess if we can bring people together and do something great for osteopathy, especially here in New South Wales, I guess why not? So that's, yeah, but thank you for answering that. Tell us more about the block mode. We kind of moved off that topic.
Yeah.
Explain that to people, because especially a lot of the more experienced osteopaths wouldn't know what that was. Tell us about that. What happened there with the block mode, and what that's all about, and what are some of the good things you think it's created, and what some of the cons to it?
Yeah, sure. So in most universities, they'll have 2 semesters, and in one semester, typically they'll have 4 subjects running concurrently over the span of that maybe 12 or 13 week semester. We used to do that, and going back in 2018, the university decided to run block mode, which was in a semester. Instead of having 4 subjects, we call them units, running concurrently, they'd do them in sequence. They'd do one for 4 weeks, and within that 4-week period, it would be fully assessed and completed. Then they'd do the next, and the next, and the next. And initially, that was going to be delivered just for the first year, and there was a specialised first year college that created just for that. But the university decided midway through the year of that first delivery that they'd actually roll it out to all year levels for every course. So that's what we did. We year by year redesigned one year into blocks, and some of them needed to be quite redesigned, and sometimes we needed to create different units. So every subject is delivered as a standalone 4-week intensive. So there are good things and there are challenges with it. The good things about it are that students just have to really worry about one thing at a time, one subject. They can get immersed in it, really, and I think that works really well. My oldest son actually last year, or sorry, no, actually he's just completed a year and a bit of a science degree at the Footscray campus, and he said it really works well for him, and I can brag about him. He's got HDs straight, so that an example of where it worked really well, and I think it works well for many of our subjects, but the challenges are that we aim to integrate the different unit knowledges and doing them in sequence instead of concurrently create certain challenges, and also with the hands-on components. And we've had a couple of course revisions and created a bit of a change of shuffle of subjects to better intersperse and represent hands-on in some year levels, like the second year we started off with just 2 hands-on clinical skills unit and created a third, and so on. So it certainly, I think, creates challenges from the integration point of view. However, despite our concerns, if our metric is how well they're doing, they're still doing just as well. The grades overall aren't different from prior to block mode. So I don't think the students are at all suffering from that challenge, and many of them say they really like that approach of just focusing on one thing, then moving to the next.
Right. Have you had any industry feedback on, I guess, what graduates are coming out like? I mean, it's all well and good to say that grades are good, but if graduates are graduating and the clinics that they're going to work at are having to, I guess, fill in the gaps, that then may not be a good thing for the profession.
Yeah.
So have you had any industry feedback in terms of how that block mode has changed or how it's affected new graduates?
I mean, yes. We get feedback all the time, both just informally from occasional, face-to-face conversations with people, to emails, to more formal things like we have a program advisory committee where we have some osteopaths, industry osteopaths, and representations from the board and so on give feedback as well. And look, overall, to generalise, the feedback has been good. Undoubtedly, COVID has created some issues, and I think we've had maybe a few years where they haven't had as much patient interface.
Yeah,
now,
there's not much you can do about that.
And even through all the lockdowns in Melbourne, we at VU, wasn't the case I think in every place, we were able to continue our hands-on classes.
Yeah, right.
So they, the students didn't lack for the hands-on classes, but they did suffer in the clinic because the clinics were closed for periods. But no year level had no clinic time. They all, but a couple. I think there were 2 year levels that had a substantial amount of the clinic replaced by simulation, and then had to do a lot of catch up with patients in the following 6 months.
Yeah.
And I'm sure that has had an impact to their experience and their confidence in a few year levels.
Yeah, I spoke to Matt Cooper on the podcast, and I think I asked if there was anything that we could do as a profession to help that particular cohort of COVID graduates. Maybe something, maybe like a special conference, a yearly convocation where we can get some practitioners, experienced practitioners, put them all in a big conference centre and just help them kind of upskill, maybe what they might have missed out on. Something anyway, but I'm sure we've got enough smarter people than me in Osteopathy Australia or in the profession to come up with some kind of... Because it's not nice. It's a sad thing, I think, for people to come out and not be confident in what they do.
And I think we've seen that cohort, graduate, and it'll be hard for them for undoubtedly or harder for maybe a couple of years, and I'm sure they'll get up to speed. There are resources, there are mentoring resources that the association has. There's CPD. I'm really confident that for maybe that 2 or 3 year levels that had less experience in with the clinical interaction that in a couple of years' time there would be up to speed and you'd
Right.
never notice it. That's what I'd expect.
Okay. So let me just summarize for the listeners. In terms of the block mode, what you're saying is traditionally education would be given with 4 subjects a semester. The semester would go for about 6 months. And what the block mode's done, instead of delivering 4 subjects concurrently, and so traditionally what you might do, for example, is you might do lower limb anatomy, and then you might do lower limb neurology, and then you might do, osteopathic techniques for lower limb, and then you might do, another subject that might be unrelated. And so that's the traditional method where there's good integration between the subjects that kind of go along the lower limb. And what you're mentioning now is that the block model kind of changes that all around, and you don't necessarily have that integration, but you're taking a subject and learning it in, I think, is it a 4 or a 6 week block?
It's a 4-week block.
It's a 4-week block, and you just learn that particular subject for 4 weeks, and then that's it. It gets you do an exam for it, you put it away, you move on to the next subject.
Yeah, but then we have structured and scaffolded the learning on other blocks and other year levels. So it's not as if those students can, okay, I've done my lower limb anatomy, thank God I passed, now I can forget it. They do need to review, and if they're doing, say, a clinical skills that's focusing on the lower limb, in a block or 2 after that, they
need their lower limb anatomy.
They need to review it, and we'll often have embedded in the units in revisions to do that, and we'll expect them to retain that. And some students do that easily, some struggle with that because it forces them to have to go back and review things they think they passed and could have forgotten, but they can't forget.
Is that something that you and your team, your education team, are working on in terms of making sure the integration is maybe not lost in that block mode change?
Absolutely. It's been a big focus, to make sure that we've got, if you like, vertical integration, across a year level, and then making sure the particular subject areas as we go up years are built on, and with time to review and then integrate it into the next, if you like, level of learning in that area. And I think it's actually been pretty successful. It's not always successful, but sometimes we think, okay, that's not working well, we need to change things, and we have changed them and try different things.
When did it come in? Was it just before COVID?
Yes. Yeah.
Right.
I think. I think in first year it was maybe 2018 the first year, and then 2019, and that continued.
Well, in education terms, it's still pretty young. You're still working on it, I guess.
Oh, look, that's right. And whenever and we did it year by year. It wasn't like the whole thing changed, in overnight. And whenever you do it, it really takes a few deliveries for you to work out what's working well and what isn't. And we have fairly regular meetings to discuss how units went, and we have regular bigger meetings to sort of review the course and sometimes make bigger changes. And actually, and we're looking at doing that again. Maybe making some substantial changes in some of our year levels. Yeah.
Right. One more question I want to ask you around education. I don't know if this has been your experience, Gary. It certainly was my experience, and it's been the experience of a lot of the practitioners I've talked to on the podcast, is that they feel like that the very first subject of osteopathy, the one where you learn principles and I guess some history and philosophy, excuse me. I guess that's a very important starting point for students. It's generally where people get hooked. Like you've got this practitioner that comes in, they generally have a lot of experience, and they're telling you about osteopathy, and they're telling you about cases and things they've seen in their own clinic, even the mistakes they've made and how they were able to recover those mistakes and then do well. And I guess it gives you a bit of a passion when you first start out, because the years ahead of you as a student are pretty tough in the medical science field, and I guess you have to have a bit of that passion. Is that something that's heavily considered with the course at Victoria University? I was speaking to John Pitcher yesterday, he actually offered, he said, I would love to come down and teach first year osteopathy and really be somebody who can deliver 40 years of osteopathic experience. That's John speaking, and he's very passionate. And I guess, you know, John, you could probably have a chat to him, but I'm just using that as an example. Is that something that's heavily considered within that course to make sure that that very first time that we have contact with students and we really give them what, I guess, you know, you discussed this earlier, what is osteopathy, but, you know, give them at least a historical understanding of osteopathy. They can go and figure out the rest on their own, and they might go, no, don't like that, it's garbage, that's fine. But at least we give them the historical, I guess, concept of what osteopathy is and how it could be used to really help people. Is that considered at VU, and do you put things in place to make sure that that gets delivered in the very first year? Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So, the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes, so for more information, please see the show notes. Now, enjoy, and back to the show.
Look, that's a good question. And
you've taught that particular subject, right? Like that's part of your background.
That subject I used to teach, History and Principles, doesn't exist in the current structure because everything had been restructured in a couple of course changes. So their first introduction is actually the way that the first year structured is a general university course. It's sort of like an academic skills course. It's evidence and academic skills. The first osteopathic unit they get is our Clinical Skills 1, where they get some of that, but it gets straight into the focus on upper extremity and deals with some of the principles. So in answer to your question, yes, but probably not as well as we'd like, and as a team we have discussed exactly that recently, and are looking at we're hoping to rejig things so we actually have exactly that introduction unit that we, in the last block mode course reconfiguration, we didn't have because it was integrated into the existing clinical skills. So acknowledge what you're saying. I think that's a good idea. I don't think we do it well enough, just in my view, and I think some of the others feel that too, and we're looking at ways to improve it, maybe creating a new standalone unit like that.
You might have to pick up the mantle again, Gary, and go back to teaching principles and philosophy, mate, or give John Pitcher a call.
Yep.
Yeah. Look, Gary, you've been very generous. Yeah, go ahead.
Oh, that's right. And I guess on that point, what I also want to say is the course team, like any course team, is always constantly reviewing units, trying to make them better, and sometimes that works well, sometimes it doesn't.
Yeah.
And it's but that is one area, and generally how students pick up their osteopathic identity, and sense of belonging through the course, and we've noticed, probably block mode has also created more of a challenge because we don't have lectures where everybody in a year level is together.
Yeah.
They're in smaller groups. So
I spoke
we're
to
now looking at.
Sorry, I spoke to a recent graduate from RMIT on the podcast, Jonathan Booth, a couple of weeks ago. I think that might have aired already. And he was quite disappointed because he graduated at RMIT and felt like he received a great health science degree, but didn't feel like he received an osteopathy degree. And I guess that's his feeling, and he's entitled to it. And after that podcast, I had a few people from Victoria University privately message me and saying, hey, we kind of feel the same way. And so I guess that's why I'm asking that question.
Yeah.
And the fact that you've answered it and said that the education team's looking at it, which is great, that's fantastic. Because I think it's a real need, and I think it helps new graduates also through those first really tough years of practice, and helps them through their years at university. So if that can be brought back in, I guess that's a win-win for the profession. One of the other things that I spoke to you about tonight that really came, I guess, a little bit of a surprise is the fact that nobody has spoken to you about a course in Sydney. So I'll be following that up because that's something that's important to us, and I guess that's an eye opener for me that we had this conversation. But other than that, Gary, mate, I just want to thank you for your time tonight. I know it's late, and you've been very generous with your answers, and I've really thoroughly enjoyed this conversation. Is there anything that you want to share with us that we haven't asked you tonight that you want to kind of let people know? Maybe some of the challenges that you've got kind of at VU that people might not know about?
No, I don't think so. We didn't get onto the topic of evidence-based medicine and evidence-based practice, but maybe that could be another time.
No, hold on. let's go there because this is what people have asked. So yeah, the question on that is obviously the impact of evidence-based practice, and given that your experience in research and the way things are moving towards evidence-based practice, and your particular introduction of being, I guess, evidence-informed rather than evidence-only, can you speak to the spectrum of evidence, I guess, pros and evidence cons? Like if you totally swallowed the evidence-based pill and went down that way versus somebody who just totally disregarded the evidence, where do you see osteopathy fitting in that, especially given the fact that you're running a course?
Oh, look, I think it's important to, particularly a course to embrace evidence-based practice. But if we think of the original definition, the David Sackett definition in '97 for evidence-based medicine, it's the integration of the best available clinical evidence with your clinical expertise and in consideration of patient values and expectations. So that's not just saying, oh, I've only got high quality evidence to do this, so that's all you're getting. It's being essentially, for want of a better word, being informed by that evidence, weighing up how it fits with your own clinical experience, and listening to what the patient wants. And I think as Archie Cochrane was reported to say, that the evidence is there to negotiate with your patient.
How do you then explain the trend of, I guess, moving away from hands-on care? There's been a trend across not just osteopathy, but a lot of the other manual professions.
Physiotherapy and yeah.
So how do you explain that? I mean, not that there's no evidence for manual therapy. There is evidence out there for touching people, I guess, therapeutically. How do you explain that?
Oh, I think there are trends, everywhere, and I think it's more than a trend. Is pain science and pain education, but the trend is that, wow, this is all we need to do. All we need to do is explain pain to people, and they should get better.
Yeah.
And I think I don't think that's a good approach, and
right.
And it certainly doesn't sit with osteopathic practice.
Yep.
It's sort of something that I believe we should be integrating into our practice, but that's not saying
you're starting to define it now, Gary. There you go. You're starting to define osteopathy now.
Yeah. So and sometimes, I'm a big believer in osteopathy, like anything, evolves, and not to be fearful about it, and it will change, and it has changed certainly in my career. I particularly as evidence changes, we modify what we do, but touching people, moving people is just so important. It may be often we have beliefs about what we think the reason is the treatment works, that we find out later are wrong, or we've got a better idea of why it works, but it still works.
Yeah.
And so
I guess we don't need
I'm
to know really why it works, but more that it works. Would that be a correct statement?
look, probably yes and no. I think working out that it works first is a high priority, because if you find out it doesn't work, there's no point trying to explore why it works. But I think you can do both concurrently, and I think sometimes the explanation for why it works can actually give you insights into how and when to apply it better. And I think what look, it definitely thoughts on therapeutic mechanisms, physiological mechanisms, and so on, has changed over the years. I think we've had better insight into some things. Into some respect, we've thrown things out, and when evidence shows that, for instance, a physical test is unreliable and invalid, we shouldn't keep doing. You're teaching that. We've got to say, okay, well, look, it's not just one study, but it's a whole lot of them. We've got to accept at some point, evidence if it is compelling, and move on. Now, I think in a lot of cases we've got mixed evidence, and there's no compelling. It's unclear, and I'm not. I'm a pragmatist, in practice, and I think some people can get a bit very black and white, with how they apply evidence, but then they're moving away from that original definition of evidence-based medicine, which is the integration of the best evidence, with your clinical expertise and patient experience.
I spoke to Nick Lucas about this on the podcast that I did with him, and he described, I guess, evidence-based practice as average practice. It's the best of the averages that we have. Can you comment on that? Would you agree with that statement?
Okay, so I presume you're sort of meaning like randomized controlled trials, finding the average effect.
That we can apply over the average population, I guess.
Yeah, but that's not to say that the results will be average. I think what we're seeing is, on average, what works, what doesn't work. And it's evidence to inform you to think, hey, if I do this approach or I add this, the chances are we're going to get a better result, because we see that in a whole group of patients. So I take a little bit of issue with that. And then we've got pragmatic trials too. Some people say, well, you can't test osteopathy because I do different things on different people. I think you can test that, and we've got lots of studies that are pragmatic design, where osteopaths just do their stuff, their usual stuff on people. What we're interested to see is, does doing their stuff, however they treat their patients, does it produce better outcomes than either not being treated or the next best care?
Are they more longitudinal trials that you're talking about, like things, following practitioners around over 10 years and seeing what their outcomes are like?
No, I really mean randomized controlled trials that are pragmatic trials.
Okay.
So the
practitioner just does their thing, and you note it down, and you see what the outcomes are like.
Yeah. Now, the limitation to that is you don't know exactly what part of what they're doing is working, and there might, and you need multiple practitioners and multi-centres, to make sure it's not just too idiosyncratic to one practitioner. But we have some of those studies, and generally they're pretty positive, showing clinically relevant results. So I think these things, are testable, and I think I don't believe you can dismiss the whole evidence thing by saying, I treat a patient differently, so it's just N equals 1, and therefore none of that research applies to what I do. I think I don't agree with that interpretation.
All right, that leads me then to my next question, and that is, I guess, you mentioned N equals 1 and the application of evidence across, across different people, and every patient is different. my next question is then, when you look at clinical trials, and especially the trials that you've been in, well, not the trials that you've been in, but the research that you've been involved in, do you find that over the course of, I guess, the research over the last, however, maybe 20, 30, 40 years, do you find that the research has caught up to what we've been saying as osteopaths on certain issues, and on other issues maybe that we've had to rethink some of our models? Has there been any time where you've looked at it and gone, hold on a sec, osteopaths, we've been saying this for a while, and now the evidence has kind of come to that conclusion? Have you come across that at all, Gary?
I think I think a common theme with osteopathic philosophy is holism, and that we work as an integrated whole. And I think we do see that with a lot of research that it's both the interconnectedness of effects, and you might see this on pain, like treating one area produces reductions of pain more generally throughout the body, and maybe have a summative effect, and also the holism aspect of the psychosocial aspects that
or the biopsychosocial, and that's body, mind, and spirit.
We've always been good at the bio.
Yeah.
Maybe not as good.
Well, that first principle, the body, mind, and spirit, the person is a unit of body, mind, and spirit. I mean, if that's not psychosocial, I'm not sure really what is. I mean, and that principle's been around as long as I've known osteopathy. So I guess that's something that's caught on with the evidence. I mean, the evidence has kind of moved us in that direction. Would you agree with that?
Oh yeah, I mean, it's usually expressed as the body as a unit.
Yeah.
They're the Kirksville tenet, but rather than body, mind, and spirit. But there've been additions. I think it was the Rogers addition. But
I was taught it as I think that the body is a unit of body, mind, and spirit. Okay, but I guess there's that. You've been to Kirksville, so you'd know more than I would. Is that different than what?
Notwithstanding what the original tenet said, I think there'd always been an emphasis on whether it be mind, spirit, how you'd describe that. I mean, Kirksville's located in the Bible Belt, as well, and one of the things that struck me was, that there's strong, Christian
overtones,
religion, which was interesting for me, being a secular Australian, but and that sort of had always been probably wrapped up with the concept of osteopathy, the spiritual dimension.
Okay. Let me dive a bit deeper into that. Being a secular Australian, has that presented a problem for you? The spirit aspect of it, is that something that you would kind of say, well, I'm a secular Australian. AT Still was probably a very avid Christian. Him talking about the spirit, I'm not really sure where that comes from. Has that something that was that something you struggled with?
No, I don't think I struggled with it. Just my concept of spirit would probably be more mind and sort of sense of positivity and positivity, a sense of purpose and things like that. That's how I would describe it. And I think everybody needs that. If you're not, you don't know, you have no drive, ambition, or sense of where you belong, then that's going to affect your psychology. And still was a bit of a radical thinker. He wasn't a traditional Christian, and he was denounced from the pulpit, and for healing with the laying of hands, and and so he was not a conventional thinker, and not a conventional religious person, though he clearly was religious.
Yeah. One of my recent kind of thought processes on this particular matter, especially of spirit, I mean, I come from a different, my background is a Christian, right? But I always thought about it, and I'm like, hold on a sec, if osteopathy works, and if the principles work, and they ring true.
I think we're frozen.
And what I mean by true is I mean that they are orientated towards the greater good. Then they have to also do that to secular people. That as a secular Australian, you'd have to think in that way as well. And it got me thinking. I mean, when AT Still talked about spirit, yes, he was a Christian, but I think what really sparked my interest in this was that I was listening to a lecture by Jordan Peterson, the psychologist, and he did a whole series of talks on the biblical stories and some of their meaning, and he was talking about the spirit as a pattern, and the way he described it was like, well look, when you see a young kid and he's very playful, you'll say, Jesus, he's got a playful spirit, because it's a pattern of behavior, right? So you see that pattern, and that pattern is what the spirit is. And then it got me thinking, I'm like, but that's what we do as osteopaths. We really look at patterns. We look at patterns of dysfunction, we look at patterns with strain patterns and mechanical patterns and patterns of behavior and lifestyle patterns and how people are sleeping and how they're sitting behind an office desk, and all these patterns that we have to kind of integrate into a clinical picture. That really gave the spirit aspect a different dimension. Do you have any thoughts on that, or basically what I just said? Is that something that you've ever thought about?
Oh, look, maybe not too much. I mean, I don't see the concept of spirit as being a metaphysical thing. I tend to think it more as a positivity of mind, or that's at least how I...
Did you ever see yourself as a practitioner kind of looking at patterns and, I guess, patterns of dysfunction?
Oh, for sure. I mean, you have pattern recognition, as a practitioner. It's one of the methods of clinical reasoning.
Yeah.
As far as, and you did freeze, and I missed some of what you said earlier, but I'm not clear on what you mean as far as patterns in what spiritual characteristics.
Well, yeah. So like, for example, it was said that when you look at a young kid and he's very playful, you'll say that kid has a very playful spirit, because it's a pattern of behavior, and so we can liken the spirit to a pattern, and I guess maybe that's what Still meant when he talked about spirit, not just in a metaphysical sense in terms of a religious sense, but also in terms of pattern recognition, and that part of that spirit is you being able to recognize patterns. That was my point that I was trying to make. And I guess I discussed this with certain osteopaths, or osteopaths, not certain osteopaths, but just osteopaths, and I guess some of them will kind of go, maybe not. And I guess I wanted to discuss that with you, because you've been around for a while and you've been to Kirksville. So I wanted to mention that to you and see what your thoughts were.
Look, I don't think of spirit in probably in that context much. For me, it's sort of part of what I would consider mind, personality,
right?
That part. So I haven't thought about things the way you've just described them.
Okay. All right. Well, going back to the I guess the evidence-based track that we were on earlier, moving that way and moving into the future, with the evidence the way it is, and I guess with education the way it is, in terms of, I guess it's taking on more of an evidence slant, which is fine. There's nothing wrong with that. I think university institutions are going that way, not just for osteopathy. It's not like it's a conspiracy. They're all heading that way for all the courses, really. How do you see the future of osteopathy in terms of education, but also in terms of, I guess, its growth in Australia?
Yeah, look, I mean, as far as evidence-based practice, that's
here to stay
for a while. It's here to stay, and assuming it's applied appropriately, and there's been a bit of a reaction against it in some ways for being, misapplied. People like Trish Greenhalgh have written about the challenges, of EBM and what should be real EBM. But put that aside. All professions are. It's not just the institutes that are teaching it, but the professions are more and more finding that they're trying to justify themselves with evidence because they know, that makes sense. And when a new bit of evidence occurs, maybe in the area of managing pain, osteopaths, chiropractors, physios, everybody's going to say, "Hey, we do that too," and move towards that direction. So, I think the likelihood. I mean, we've seen some convergence, I think, in styles of practice over the last 20 years between the main manual therapy professions, in part because we're all being guided by a similar pool of evidence. But also, we've got dissemination of knowledge. When I studied, we had a couple of lecturers who jealously held on to their copy of Coutura, for fear that the chiropractors, would grab hold of it and steal the secrets of osteopathy. That might sound absurd, but it happened.
Yeah, right.
These days everybody can look at everybody's evidence and
everything's out there,
and their philosophy. It's all out there. So, I mean, inevitably, I think we do grow closer and closer together, and I think we'll continue to do so. I think there'll always be, a cultural identification of osteopaths, with osteopathy. And we know even within osteopathy there's a wide range of practice styles, as there is with chiropractic and physiotherapy.
Yeah.
But I think we'll have that identification more and more where I've talked about more broad capabilities that our graduates are coming out with. We're finding, many of our grads are deciding not to go into private practice, but into occupational rehab and aged care and other things. And we're seeing, jobs for occupational rehab being advertised for physio or osteopath.
Yeah, right.
And this is happening more and more. And it's really, I think, the sign of a maturing profession. We're no longer a closed guild, with their secrets. We're become a profession where we're no longer alternative, we're no longer complementary, we're part of the allied health body, which is a good thing. And but it does mean we're changing, and that can be upsetting for people that identify with the way it used to be.
Yeah. I guess then the next question on that is, what do you say to those people that say that osteopathy has a weak evidence base? Because you're telling us that we're sharing evidence across the board, especially when government, I guess, are doing things, say, with professions that have, I guess, larger numbers like physiotherapists, and we might miss out on some things. Look at NDIS, I guess. Speaking to Matt Cooper, they've been having issues with getting NDIS recognition on certain things with osteopaths. And I guess if the litmus test is the evidence base, and we're all sharing the same evidence base, what response do you have to those who say that osteopathy has a weak evidence base?
I'd ask them to be more specific. What do they mean by that? Do they mean, because as far as managing things, the common conditions that we manage, back pain, neck pain, and so on, we've got quite a reasonable evidence base. Now, our evidence might be drawing on studies done by osteopaths, but also techniques we use done by other professions, but I think that's reasonable to draw on. It's in that sense, it's no better or worse than the evidence for physio, treating back pain. If you're saying, well, it's, what I mean is osteopathy, just osteopathy itself, done by osteopaths only, is weak. Look, we'd have to say we have evidence. We've got a number of randomized controlled trials in a number of different areas. Many of them are, weak level evidence or high risk of bias, just simply because, they're not big funded trials. We don't have many big funded osteopathic specific trials, but you know, given that limitation, you know, we can also justify, you know, from the wider pool of evidence from other professions and the trend is, or has been for some time, you know, to not make research profession specific. You know? So I would say, you know, weak evidence in some areas, stronger evidence, you know, for treating other things. With the NDIS, probably it's more to do with is the osteopathic training of in osteopathic institutions, you know, well suited, you know, to deliver care for NDIS, and probably it hasn't been, but it's slowly, you know, it's changing a bit to meet that demand.
Yeah. All right. Well, Gary, mate, I want to get you to hang around a little bit. I want to ask some specific questions for my particular students, not for very much longer.
Sure.
But for everybody else, for the public listeners, I want to say thank you to Gary for joining me tonight. You've been very gracious with your time, and I've thoroughly enjoyed it. I've learned some things tonight too. And so I hope you've enjoyed it, mate, and maybe we can come back and do a round two. I know that you're speaking at the convention, I think the Osteopathy convention later on in Sydney. So hopefully we get to see you in Sydney at that time. But other than that, I will link to Gary's email, I think, to if people want to reach out to Gary, they can do that via email. But mate, thank you for your time. Hang around, hang on with me. But for everybody else, have a good evening, and we'll see you on the next episode.